Tēnā koutou katoa, no te whakatohia me Ngāti Awaahau. I acknowledge the mountains, the lands, the rivers, and the seas of our Indigenous hosts. Welcome to the sub-plenary session, Indigenous Community Mobilisation, Decolonizing Policies to Promote Equity in Health and Wellbeing. This session was developed by the Tahati Consontoje Quebec Network Environment for Indigenous Health Research, and it was organised by Treena, Delormier and Sonia, Périllat-Amédée. Over the next 90 minutes, we will have the privilege of hearing 3 presentations from Indigenous community health promotion leaders. And as many of you will know, there are 3 recognised groups of Indigenous peoples in Canada: First Nations, Inuit and Métis. Each group of course have their own unique histories, languages, beliefs and practices, and we'll be fortunate to hear from a speaker from each of these groups. The speakers are going to share their stories, their knowledge, their perspectives and their experiences of Indigenous community mobilisation, of decolonising policies to promote equity in health and wellbeing for Indigenous peoples, and of culturally based health programming within their communities. And this sub-plenary will be one of the many strands of the conference that will contribute towards the legacy statement that's being developed as a product of the conference. Well, the presentations have been pre-recorded. 3 presenters will join us live during this session to discuss any issues or answer questions you may raise. So for everyone joining us here on Zoom today, we want to hear from you and invite you to ask any questions that you might have for our speakers. As I've said, my name is Mihi Ratima and I affiliate to the Whakatohia and Ngāti Awa tribes of Aotearoa, New Zealand. My background is as a university-based academic in Māori health and health promotion, but for the past 15 years I've been living in rural Taranaki on the west coast of Aotearoa, New Zealand. So I've been working from here as a community-based scholar working with Māori communities in health promotion research. But now I would like to turn to introduce the first presenter that we have here today, and that is Minnie Gray, who is going to speak on Inuit culturally based health programming. As many of you will know, Minnie is a renowned Inuit leader, and she's demonstrated for more than 30 years her commitment to Inuit wellness in her community in Nunavik and internationally. Since 2013, she's been the Executive Director of the Nunavik Regional Board of Health and Social Services, and she works on the implementation of Inuit culturally based health programming, ensuring that the health services are rooted in Inuit culture, language, knowledge and practices. And over the years, she's held several positions in the field of health and social services, including negotiator for Nunavik's autonomy, Vice President of the Canadian Office of the Inuit Circumpolar Council, and a member of international and UN committees. And of course, her commitment has earned her many awards over the years, including the Public Service Award of Excellence for the National Foundation for Aboriginal Achievement, the Jubilee Medal, the Companion Title of the National Order of Quebec, and the Charter of Quebec Human Rights 40th Anniversary Award. And she's also a member of the Order of Canada. So thank you so much for joining us and agreeing to share your knowledge, and I'd invite you to start your presentation. Thank you.
I was
Conseil, good afternoon. Thank you for joining. Conseil, good afternoon. Thank you for joining us today and for the opportunity to share our work on Métis health research and data governance. I'm speaking to you from the homeland of the Métis and Treaty 4 territory. My name is Marg Friesen, and I have Adel Panahi, the Director of Health for Métis Nation Saskatchewan, here with me. I'm the Minister responsible for health for the government of Métis Nation Saskatchewan. Métis Nation Saskatchewan is the government representing Métis citizens in the province, and our health department advocates for the improved health and well-being outcomes and improved healthcare services for Métis citizens across the province. It's important to frame the conversation by acknowledging the legacies of colonization. The impacts of past and present colonial policies with respect to Métis people are often not well understood or addressed. Métis are distinct Indigenous people with unique health needs which require specific attention. The past and ongoing legacy of colonization, including oppressive system policies such as the loss of land, residential school experience, 60 scoop, federal and provincial jurisdictional battles, and systemic racism have all played a significant role in the lives of Métis people. Root causes of poor health outcomes suffered by Métis people, such as intergenerational trauma caused by colonial policies and adversity in childhood experiences. As a result, Indigenous people face poorer health outcomes than the general Canadian population.
Good day. My name is Minnie Gray. I am the Executive Director of the Nunavik Regional Board of Health and Social Services. I grew up in a small community practicing traditional activities, and then, as was the practice of the government in those days, I was sent away to Ottawa at the age of 14. This experience, leaving my family and traditions, was not easy, but I believe it has encouraged me to know the best of both worlds. I've been involved in the health sector for 30 years, as well as having various elected positions in local, regional, and international organizations. In order to understand the policies and practices that are being put into place in our region, it is important to understand who we are and a bit of our history. Inuit originated in the Arctic of the circumpolar regions. In my region called Nunavik, Inuit make up 90% of today's population. The other 10% consist of people coming to the region to work with us, and some have stayed to bring up their own children. Today, the region of Nunavik consists of 14 communities with populations between a couple of hundred to a couple of thousands. The communities are not accessible by road. We travel by plane and at times by boat and skidoo to see family in other communities. But traditionally, we lived in smaller units before the communities were developed. My ancestors, my own mother and grandmother, lived on the land as nomads, surviving off the land, living in igloos in the winter and tents in warmer seasons, traveling by dock team, kayak, and even by foot. This was as early as 60 years ago. Our people have experienced rapid social change in such a short time, from those days to the technology that we live with today. Some of these changes included being removed from our way of life, from our families, to attend schools, the introduction to infectious diseases such as tuberculosis that forced people to live far from their homes in sanitariums for treatment. This was the start of the unraveling of our strong social structures. Despite all that, we have survived, being adaptable and resilient. We maintained our language, our way of life, to enjoy our traditions, our clothing, our food, living off the land. Our youth are comfortable in the two worlds, speaking 3 languages, English and French being the second and third languages. But we are still in a situation where youth are not able to continue their higher education in our own communities, So they have to be sent away still to major cities to continue their education, which is a major challenge for many. Regarding the health and social services in our region, the federal government was in charge of dispensing health care, but with no permanent structures in our small communities in the older days. A doctor would fly in occasionally, or the Hudson's Bay manager was in charge. In 1975, Inuit of Nunavik negotiated the James Bay and Northern Quebec Agreement in response to the major hydroelectric dam that was being built in James Bay. We were the first Inuit to ever sign a land claims agreement. The James Bay and Northern Quebec Agreement was then implemented to create the various institutions that we now administer under the Quebec legislation. Within our own sector in health and social services, we have an all-Inuit board, but many of our professionals are non-Inuit, mainly because of these issues related to obtaining higher education and the policies that make it impossible to do clinical work without being part of a professional order. Policies also influence salary and benefit disparities between professionals and Inuit working in the system, but who don't have those clinical titles. We have issues such as high turnover of clinical staff, many not being trained enough to understand our realities, families not feeling 100% comfortable with the type of services that are offered within the regular institutional services, which are not always adapted to our way of life. In many ways, there is an application of foreign laws that are not culturally relevant, which creates situations of unequal access to services for our families, not enough prevention and first-line services, too much youth protection on signaling, and constrained crisis interventions. Challenges have included the loss of our youth, and we're trying desperately to address these deaths of despair. We are doing this in our own way. We have created an annual event called the Puttauti, which is a suicide prevention and well-being program where we do reach out, safe talk, generational trauma healing, support one another, and this conference is done by Inuit for Inuit. We are doing many things to address these different challenges. We are creating our own initiatives to address the issue of policies that come from the foreign system to make services more culturally relevant and safe. I have a few examples. Sahayuk, meaning a change in the wind direction, is an initiative designed by the Nunavik organizations and is administered by the Health Board. Its purpose is to rebuild Nunavik society and its family structures through a better awareness and support programs combined with direct and rapid access to justice and health services adapted to our regional and local needs and offered in cooperation by all government, regional, and community organizations. It is intended to ensure coordination of services delivered by the Quebec Ministry of Health, Ministry of Justice and Public Security, along with our regional and community stakeholders. By clarifying the roles and responsibilities of Quebec, regional and community stakeholders, Sahayuk aims to improve the continuum of services for those in needs. The goals include improve how services are delivered during crisis situations, reinforce the input of the local justice committees in the judicial process in all levels of intervention, reduce the number of repeat criminal offenders by adapting rehabilitation to regional authorities and Inuit values, promote awareness and prevention programs to fight drug and alcohol abuse and the resulting violence and crimes, and to support intervention and services for residents at risk and in difficulty, improve the provisions of psychosocial services, addictions, mental health, troubled youth, etc., and increase the number of addiction treatment spaces in Nunavik and access to centers in southern Quebec. The main objectives of this program is to curb alcohol and drug abuse with a view to reducing physical and psychological harm they cause, as well as resulting overrepresentation of Nunavik Inuit in prison. Nunavik-UIPES, NIP, an integrated family service vision. In 2013, the Health Board initiated a review of the protection services provided to youth in Nunavik and how this clientele could benefit from special cultural and regional adaptations. Following this review, the Regional Advisory Committee on Youth Services was created. In 2017, this committee hired an Inuit woman as its integrated youth and family advisor with the task of setting up an intensive consultation on the application of the Youth Protection Act, YPA, in Nunavik. A group was formed with members from the elders, regional leaders, youth, women's association, and key stakeholders. The group was named Sukait, meaning the pillars. Their conclusion following the community consultation was to create the Nunavik-UIPES, which would encompass all youth services and oversee the implementation of the YPA to be more culturally relevant and sensitive to the Inuit way of life. We are presently working on an agreement with the Quebec government to use Section 37.5 of the YPA, which allows Aboriginal communities to take on the responsibility of offering services that fit into their realities. This would then allow Nunavik to create a system better suited to our communities, the families, and the youth. Far too many Inuit children become separated from their families, communities, and many end up in the youth court system. This new initiative by Inuit for Inuit is intended to keep families together by giving them proper and culturally sound support. These are only two examples of how we want to see our culture integrated into these foreign services, which are not always adapted to our realities. Other programs we're working on include the Nunami on the Land program, which promotes well-being on the land. Our traditional activities on the land are very therapeutic and good for our mental health. Nunavik family houses designed with the community in mind and respectful of our culture and our language, fostering child development and supporting parents by providing them tools that will contribute to this development. Putautit Suicide Prevention and Healing Conference was initiated some years ago, and we have designed a model for presentation and promotion activities based on the experience of this conference, giving more opportunities for smaller communities to receive more sustained attention for grieving and healing activities. All these initiatives created by Inuit for Inuit have our culture, language, and traditions as foundations for providing services that are more sensitive and understanding of our way of life and all that is part of us. Our ancestors survived on the land despite harsh environments. So as modern Inuit, we want to take their strength, their resilience, and their adaptability to ensure our well-being and to give a brighter future to the next generation. Nakokmi, thank you, merci.
Kia ora, and thank you, Minnie, for pre-recording that presentation for us. I just want to make a few comments before we move on to some Q&A. So I really encourage everyone to, if you have any questions, please put them in the chat. So Minnie talked about the application of foreign laws and policies and provision by outsiders and how that hasn't worked for her communities. She characterised the community mobilisation approach they have taken as by Inuit for Inuit, with Inuit culture, language and traditions as the foundation for providing services that are more sensitive and understanding of their way of life and all that is part of them as a peoples. So essentially it's about Inuit leadership and delivery, services founded on Indigenous knowledge, and therefore provision that's relevant to Inuit ways of life, including promoting wellbeing on the land and traditional activities on the land. So provision that can really contribute to rebuilding Inuit society and family structures. And these are things that I think resonate for many Indigenous peoples. There's also an intergenerational orientation, so taking the strength, resilience and adaptability of ancestors as an inspiration to ensuring well-being, and also seeking enduring benefits. So not only benefits for those that are alive today, and particularly the young people, but for future generations as well. The approach, I would say, fully aligns with the aspirations expressed by many other Indigenous peoples around the world for greater control of their own health and well-being and of health and social service delivery, and provision that normalises our beliefs, our values and our practices. To work within existing systems and policy frameworks, but about making adaptations that enable more decolonised service provision to communities with greater control for Indigenous peoples. And here in Aotearoa, New Zealand, in some areas, our policies are beginning to better reflect Māori ways of seeing the world. So, for example, generally traditional housing policies from government have been about affordable accommodation for nuclear families, so for mum, dad and a few children, and also about supporting conventional models of home ownership with individualised land title. But in recent years, in response to the housing crisis we have here, there's been a shift in policy to support papakainga housing. So that is Māori co-housing, often on communally owned ancestral land. So about enabling us to do things in ways that make sense to us. I want to open up now for questions on your presentation, Minnie. If the technical people could please share the screen with me with questions. Okay, well, I'm not having much luck with that. So I'll just get started with a, oh no, here we go, maybe. Well, I'll just get started with a question of my own, Minnie, which is around thinking about community developed policy. Are there particular policies that you're developing in the community or that have been developed and support the work that you're doing, as opposed to adapting your programs so that they will function and work within the policies of outside agencies?
My apologies, but my internet is very unstable, so you were cutting off, so I didn't get all your question. Could you repeat? I'm so sorry.
Oh no, that's all good. So hopefully you can hear this. You were speaking about how policy introduced by foreign groups isn't working for your people, and so you've delivered by Inuit for units, Inuit service provision. But I was wondering, is there policy development work internally that's being carried out, policy that's developed by yourselves, by your own people, and that is supporting the work that you do?
Okay, thank you for that question. Yes, for many years, I'll just explain very quickly. For many years, the services that were given are developed for us in the South, I mean, I'm calling Southern Canada the South because I'm in the Arctic. And the norm was always, well, the people bring up the services and they deliver them. Historically, I mean, we need these services, we need healthcare, but historically, they were not always suited, and we had to adapt a lot of these programs and services. But now we are developing much of the programs and the services based on our needs and our realities. And I can say these are very well accepted and recognized by our funding government, which is the Quebec government. So they are providing us adequate funding. Well, we can't say it's always adequate. We're always saying we need more, but the programs that we have developed from the grassroots and from the community level have been recognized. For example, the Sahayuk program and the Nunavik, which deals with the youth services. We have to, in order to deal with mental health, we have the On the Land program, which is so important to us as people from the land. Yeah, yes, they are gaining recognition, which I'm glad to say.
Thank you. And we've had a question come in, and I can see it now. So I'll just read it out to you. What can you share about what it takes to engage successfully with governmental agencies with the goal of integrating Inuit ways into existing policies? And what could be done to make this engagement process easier or more efficient?
I can say that it takes a lot of partners in my region. For example, we have two health centers, one on each coast, because we have two coasts in our region, and it's a collaborative work. It's partnership with people that are on the field, organizations that are part of our network, but it's all about planning and programming, in which we engage our board of directors of the health board and the board of directors of the health centers, and it takes a lot of promotion, communication with our users, our people in the communities, and leadership, and then with that we make presentations, and we go to the right ministries, especially the ministry that funds the services, health and social services here in Nunavik. We have to do a lot of educating, because many of the bureaucrats or different levels of the ministry really do not understand our realities, and they don't come often enough to see our everyday challenges. So it takes a lot of promoting, it takes a lot of educating, and it takes a lot of meetings and doing action plans in order for them to understand that within this particular sector, for example, mental health, we don't always have psychiatrists and psychologists available, although they do their visits through the health centers. So we have to make our own programs, such as the Nunami program, as I mentioned earlier. Nunami program means going out on the land with your family, with your community members, and healing and work with our traditions. So it's many faceted, it's many steps, but slowly but surely, I think we're gaining ground. I know we're gaining ground, because we all these examples that I presented are now recognized as fundable.
Thank you. And another question, could you provide some examples of how healthcare delivery can be adapted to the culture and needs of the Inuit people?
Well, that's something I don't have a quick answer to, but I've been in the health sector almost 30 years. And from the first day I sat in an executive director's chair in the hospital here in Kujua, there's been many changes. We worked a lot with how the educated people, the doctors and the nurses, were the leaders in delivering health and social services. But as Inuit boards started to come on, people like myself, although I'm not a nurse or a doctor, as one of the leaders of Nunavik, I've taken it upon myself to have a very strong vision, a vision that I can share with the government people, a vision I can share with other Indigenous people and with my people, so that vision is understood, and that we can no longer work the way it used to be. It has to be from us. We still need professionals, because many of our people are not at the educated level where they can become doctors and nurses or even psychiatrists. But this is something that we've taken upon ourselves as the health board, that we are promoting our Inuit employees to gain further education through working through universities and colleges. So there's, like I mentioned earlier, there's many steps in place, but I think support from the board of directors that are all Inuit, support from other partners that are key in developing our communities and our healthcare and our education. In particular, we are protected under the Constitution, because the Land Claims Agreement, James Bay and Northern Quebec Agreement of 1975, is the basis of our ability to do this work. Although we are only recognized as public institutions under the Quebec law, James Bay and Northern Quebec Agreement gives us the power to be able to say, look, in this landmark agreement, it says that under health, these things, these special chapters or sections have to be agreed to, or have been agreed to by the government, and they have to be implemented. So there's a political side to it, but there's also a regional and local level of decision making.
Thank you, Minnie. I'd like to just express the gratitude for that you've taken the time out to provide this presentation to us. And I'll now move on to introduce our second presentation, which is Community Mobilisation for Healthcare System Reform via Joyce's Principle. And the presenter is Sipi Flamand, who's the Vice Chief of the Atikamekw or Manawan First Nations community in what is now the province of Quebec. His academic background is in Indigenous studies and political sciences with a focus on government. And he's involved in a range of creative pursuits, including as a musician, a filmmaker, and he's also a powwow dancer.
Thank you very much.
As a person, he is not shy to move away. He's not shy about taking on challenges, but he tells us that he's motivated by them, and he's a well-known and respected community activist. He's one of the instigators of Joyce's Principle, a protocol for the care of First Nations people in the province's health services. And it was proposed by Atikamekw authorities in response to the tragic death of an Indigenous mother in a Quebec hospital just after being subjected to racist slurs based on her First Nations identity. And those slurs were by hospital personnel, hospital staff. So, Sipi, I'd like to invite your presentation, which has been pre-recorded, but he is here to respond to questions after the presentation. Thank you.
Good.
Good afternoon, everyone. My name is Sipi Flamand Atikamekw from the community of Manawan, where I'm Vice Chief of the Atikamekw Council of Manawan. Today, I want to introduce to you Joyce's principle. This is a principle that was initiated by the community of Manawan and the Atikamekw Council of Manawan, as well as the Council of the Atikamekw Nation. As you may have seen a few years ago, back in 2020, a situation arose with our dear sister Joyce Echaquan, and it's in response, in fact, to this incident that we initiated the Joyce principle to work on a new approach to better work and better serve Indigenous people within the public health system. So I will share with you these realities and issues today that are related to the Indigenous public health system. It has been well documented that there are many underlying factors that have had negative impacts on the health of Indigenous people, including poverty, intergenerational impact of colonialism and Indian residential schools, and it has also been an obstacle to being healthy as an Indigenous person. Many Indigenous people did not trust the classic health care services or did not necessarily use these health services because, in fact, they did not feel protected against stereotypes, racism, or being judged, because the Western approach to medicine could create for them a sense of alienation and a sense of being intimidated or bullied. So it's within that overall approach that I'd like to talk to you today within the framework of this presentation. So on the 28th of September 2020, the tragedy occurred with Joyce Echaquan. It took place at the Joliette Hospital Centre in Quebec. The community of Atikamekw took steps then that led to submitting the brief on the principle of Joyce, or Joyce's principle. So what is this principle? Above all, it's a principle that aims to guarantee to all Indigenous people the right of equitable access without any discrimination to all social and health services, as well as the right to enjoy the best possible physical, mental, emotional and spiritual health. The principle absolutely demands recognition and respect of traditional and living Indigenous knowledge and ways of knowing about health. So it's in the spirit of cultural safety as well that we can deal with this. So why do we have Joyce's principle? As you have seen over the last few years, there have been lots of debates and discussions in the media and in the political arena to get Joyce's principle adopted, but at the current time the provincial government, Quebec, has not yet adhered to, nor adopted, nor implemented Joyce's principle. At a federal level, there's been a different approach taken, a different relationship. Unfortunately, the speaker is breaking up here. Federal government, were the final words of this sentence. So the adoption of Joyce's principle will make it possible to assert the rights of Indigenous people relative to healthcare and social services in Quebec and Canada. Therefore, this brief on Joyce's principle constitutes a reminder and a formal request for a commitment by the governments of Quebec and Canada and their institutions to respect and protect Indigenous rights relative to healthcare and social services, which are rights that are recognised internationally. We have drawn inspiration from international declarations, in particular the UN Declaration on the Rights of Indigenous Peoples that was adopted at the UN General Assembly back in 2007 with Article 24, which reads as follows. 1. Indigenous people have the right to their traditional medicines and to maintain their health practices, including the conservation of their vital medicinal plants, animals, and minerals. Indigenous individuals also have the right to access, without any discrimination, to all social and health services. Indigenous individuals have an equal right to the enjoyment of the highest attainable standard of physical and mental health. States shall take the necessary steps with a view to achieving progressively the full realization of this right. So it was within the context of this article of the UN Declaration that we developed Joyce's principle and asked the government to make a formal commitment to avoid this type of similar situation from arising once again for Indigenous people. And we launched a mobilization movement on social media as we were not able to have physical meetings because of the pandemic. So we turned to technology to get support, in particular on social media. And we also set up a web page for Joyce's principle. And we asked for everyone's support for this principle to then be adopted and supported, and we asked for a personal commitment to convey a positive message to political and institutional bodies, and asked for support for the application of the 6 pillars of Joyce's principle to support implementation of cultural safety in healthcare systems for Indigenous peoples, and also to actively engaging in the fight against racism against Indigenous people. And we also aimed to work to end systemic racism in society, and for everyone who was supporting Joyce's principle to make a commitment to be an agent of change in society. We have received a lot of support from different Indigenous and non-Indigenous organizations, and even from universities as well, who've committed to working on Joyce's principle. So we've had good support from them, and we're still having discussions together to see how exactly we can work together to implement Joyce's principle. So I referred earlier to the 6 pillars for implementation of Joyce's principle. Often we talk about relationships between Indigenous peoples and the 2 levels of government dealing with health and social services, namely the federal level and the provincial level. And we also want to work with the general public to make them aware of what's at stake in Indigenous realities related to healthcare, and especially on the issue of cultural safety. Also in teaching establishments that are offering healthcare and social service programs, we wanted to make them aware of this principle. We also ask professional orders or associations to work in collaboration with Indigenous authorities on Joyce's principle, as well as healthcare and social services organizations such as the health centres, hospitals, the CLSC, the local community services centres in Quebec, and any other organizations that work in the health sector. That is what is proposed by Joyce's principle. So how can we implement this? It's a matter of recognizing right to autonomy and self-determination of Indigenous people for healthcare and social services, and also recognize systemic racism with which Indigenous people are confronted. And once again, it comes back to a question of collaborating with Indigenous authorities in setting up an action plan for Joyce's principle. And all legislative measures need to be taken to implement Joyce's principle. Especially, we need to review the funding programs related to delivery of services in collaboration with Indigenous authorities and harmonisation of reimbursement and coverage programs with provinces to allow optimal and equitable access to healthcare treatment and drugs also. And we're also asking governments vis-a-vis Joyce's principle to actually change their approaches. For example, often there are jurisdictional conflicts. So the implementation of Joyce's principle, we're asking people there to work together, leaving aside jurisdictional conflicts between the federal and the provincial level. And we're asking for the establishment of an ombudsman office for Indigenous health to provide resources to act and to be agreed upon together with Indigenous authorities. We've also talked a great deal about collaboration and partnership and work together with Indigenous authorities for implementation of Joyce's principle. We also need to set up measures that facilitate human resources that offer healthcare and social services to Indigenous people and reduce stigmatisation and prejudices shown towards Indigenous peoples. And there needs to be important awareness and education work carried out amongst non-Indigenous people so they become more aware of Indigenous realities. There's also a question of financial support for Indigenous authorities so that they can set up awareness-raising campaigns and popular education on Indigenous realities. Therefore, we're asking everyone, each individual, in fact, each citizen, to make a commitment to report and denounce and speak out against any manifestation of racism towards Indigenous people. On Joyce's principle, we're also really moving ahead with this concept of cultural safety. First of all, this is an affirmative and transformative and reconciliatory approach which has been tried and tested in Indigenous communities in Canada, Australia and New Zealand in the last few years. And in New Zealand, that's where they developed this concept, launched it and implemented it. So we're actually learning more about their approach so that we're able to then transpose it to Canada and Quebec. The principle of cultural safety is also based on the founding principle of social justice, which recognises legitimacy of cultural and social differences related to Indigenous peoples, and also considers the ongoing lasting effects of colonialization, systemic racism and intergenerational trauma which has resulted from this. And it aims to create safe and welcoming environments for Indigenous peoples within, in particular, the health and education network. So it's not just about the health sector, but also in other sectors and areas that we have to work on cultural safety. We also need to promote deployment of practices, services and initiatives that are in keeping with Indigenous ways of caring, support, prevention, social dealings and ways of learning. And especially we have to translate a collective and community will for achieving transformation and social innovation. So tangibly, cultural safety means that we need to have cultural safety relation officers. For example, when it comes to healthcare, this would create a trusted link while recognising the reality of individual Indigenous people with their context, their reality, their history, and of course, recognise legitimacy and the Indigenous and social and cultural differences. Institutionally speaking, or structurally, we also need to set up collaboration agreements with Indigenous professionals in healthcare and social services in order to improve these Indigenous healthcare services. So in general, Joyce's principle, for me personally, means that it's a principle that would meet the needs of all cultures in Canada. And if there's political will at a provincial and federal level, then that's when we will be able to actually implement Joyce's principle. So thank you very much for listening this afternoon. Thank you.
Kia ora, Sipi. Welcome and thank you for recording your presentation for us. Your presentation reminds us as Indigenous peoples of the power of telling our own stories and charting our own way forward based on our own views and perspectives and also rooted in real lives. And we all as Indigenous peoples have our own master storytellers. So for Māori, Moana Jackson, who recently passed away, was one such master storyteller for us. He was a lawyer and a visionary who did groundbreaking work in Māori criminal justice and constitutional reform. And he espoused the view that you can't get justice in an unjust society. And this too was a message that I heard in your presentation. When you link the lack of trust in public health services to the historical and contemporary experiences of colonisation, to intergenerational trauma, ongoing systemic racism. And Joyce's principle is a clear example of community mobilisation for healthcare reform that we can all learn from. So Joyce's principle challenges governments and those within health and social systems to see that these systems do not reflect the ways of thinking, doing and being of all communities. And the system isn't fair. The problem isn't with Indigenous peoples, but with non-Indigenous systems. That systemic racism is entrenched and it's rooted in the historical and contemporary expressions of colonisation, and that it undermines Indigenous people's right to health. However, it's not a problem that can be solved if there is no recognition by governments of the problem. Systemic racism in health and social systems is not, however, it's not a First Nations problem. Systemic racism is a problem that we all as Indigenous communities face in colonised states all around the world. And there's growing evidence that, of course, demonstrates this truth. And the presentation that you gave also brought to mind a saying from Parihaka, which is a rural Māori community about half an hour from where I live, and it's of historical or its passive resistance to land confiscation by the colonial government in the 1970s. And the community continues to espouse the value of maunga arongo, which means mutual peace, which is about working together as collectives in respectful and empowering ways and towards common goals that are going to benefit all community members. And a saying from that community is, ko te pō te kaihari o te ao, ko te mate te kaihari o te ora, which translates to just as night brings day, so too can death and trauma bring in time, opportunity and life. We have some questions that have come in. My French is certainly not up to it. So if questions come in French, I'll leave it to you to read those questions out and to answer them. But we have some questions here in English, so I'll make a start. So one of the questions is it really possible to work on Joyce's principle with the Quebec government who do not recognise systemic racism in Quebec?
I think that from a social point of view and a political point of view, we often talk about cultural safety, and there's also the issue of systemic racism and the Quebec government's position on this. I think it's important to still work on Joyce's principle It's a principle that was initiated by the Atikamekw Nation, the Manawan community specifically, to stop these issues from occurring related to systemic racism. We have obtained certain points. For example, there's the Vienne Commission for Reconciliation and Progress and so on, related to public services and Indigenous communities. And there are different aspects that need to be borne in mind in order to make progress and bring about change within the healthcare system. And I think that Joyce's principle is what we've put forward. It's a paradigm shift that we're proposing and changing the way in which we look at health with Indigenous communities. And Joyce's principles aim is to create a different type of discussion within the public system and hospitals and the local community centres together with Indigenous communities. We're inviting governments to work in a collaborative way with Indigenous authorities. So I think that from a political level, the government, when it comes in particular to systemic racism, the government doesn't actually want to budge and move forward. But Joyce's principle is there as a proposal and a proposed solution in order to be able to change the system and decolonize what's happening within the public system. So Joyce's principle is the recommendation from my community. And it's been put forward by communities that work with Indigenous communities. It's been suggested by them too, in order to try and change the public healthcare system to the advantage of Indigenous communities. Now, it's true that in Joyce's principle, there are many aspects. There's 6 pillars in there, but why not? Why not come back to the table and have a summit with the governments to see how we can actually implement this principle? Thank you.
For the next question to come up. So the next question is, despite the many actions that still must be accomplished to achieve Joyce's principle, where have you found the greatest successes and support for Joyce's principle?
I think that the organizations that have supported and adopted Joyce's principle over the last couple of years show that this is a step towards taking action, a step towards changing the system. They've made a commitment. For example, the College of Physicians is supporting Joyce's principle. And this is an important body, an important institution that could bring about change. So these organizations and community organizations and professional associations, well, it's important they've given their support. And as I've said, universities are starting to adopt Joyce's principle as well. It's important for them to do that so that we can create debate and bring about social and societal, scientific and academic change so that it goes up to the political level. It's important to bring in that type of support from these different sectors so that then politics actually then get involved in this movement too. So I think it starts with the social movement, grassroots movement. That's where we can really start to bring about change. And when we're talking about decolonization, it's the grassroots people who want social change, and then the political world has to understand this vision and understand the position of all of the citizens. Thank you.
Thank you, Sipi. I think my connection just dropped out for a moment there, I think. Thank you so much for your presentation and for sharing the amazing work that you and others have been doing. A fantastic example of community mobilisation for health system change. So thank you. I would now like to introduce our third and final presentation, Decolonizing Policy, Métis Health Research and Data Governance. The three authors of the presentation are Minister Marg Friesen, Adel, Panahi and Tegan Brook from the Métis Nation, Saskatchewan. Minister Friesen and Adel are delivering the pre-recorded presentation and are supported by Tegan, who is the Métis Health Research and Data Manager. Representing the team, Adel is here with us today to respond to any questions you may have and to provide insights. Minister Friesen is a Métis woman from the Qua'apel Valley. She was elected as Métis Nation Saskatchewan Regional Representative for Eastern Region 3 in 2017, and she's a governing member of the Provincial Métis Council and currently holds the portfolios for the Ministry of Health and the Ministry of Finance. In her role, Minister Friesen is passionate about building healthier and stronger communities by connecting people to people and people to places. And she works towards building positive working relationships and fostering leadership in others. She does this by implementing best practices for community engagement to address social and economic barriers for all people and for the common good. Through the MNS and Mamawiikikayaahk Research Network partnership, Minister Friesen advocates for Métis research and data governance principles to ensure the research and data sovereignty inherently held by Métis people are entrenched in any research and knowledge translation projects undertaken within the nation. The co-presenter, Adel Panahi, who's with us today, is the Director of Health for the Métis Nation, Saskatchewan. He's a public health administration professional and humanitarian activist with more than 15 years of experience in developing and coordinating policies and programs in public sector and non-profit organisations, and has a deep understanding of Canadian policy, public policy environment and of Indigenous health. So I look forward to hearing the presentation. Thank you.
Conseil, good afternoon. Thank you for joining us today and for the opportunity to share our work on Métis health research and data governance. I'm speaking to you from the homeland of the Métis and Treaty 4 territory. My name is Marg Friesen, and I have Adel Panahi, the Director of Health for Métis Nation Saskatchewan, here with me. I'm the Minister responsible for health for the government of Métis Nation Saskatchewan. Métis Nation Saskatchewan is the government representing Métis citizens in the province, and our health department advocates for the improved health and well-being outcomes and improved healthcare services for Métis citizens across the province. It's important to frame the conversation by acknowledging the legacies of colonization. The impacts of past and present colonial policies with respect to Métis people are often not well understood or addressed. Métis are distinct Indigenous people with unique health needs which require specific attention. The past and ongoing legacy of colonization, including oppressive system policies such as the loss of land, residential school experience, 60 scoop, federal and provincial jurisdictional battles, and systemic racism have all played a significant role in the lives of Métis people. Root causes of poor health outcomes suffered by Métis people, such as intergenerational trauma caused by colonial policies and adversity in childhood experiences. As a result, Indigenous people face poorer health outcomes than the general Canadian population. One of the major barriers to achieving health equity is the significant gap in Métis-specific healthcare data in Saskatchewan because Métis are not identified in the current healthcare system. In order to decolonize Métis health and well-being policies and practices, we must first understand Métis concepts and definition of health, which often differ from Western concepts of health. These include self-determination, health is holistic and multifaceted, and health is land-based or place-based. These concepts must remain at the forefront of all the work we do as a nation and with our partners. The United Nations Declaration on the Rights of Indigenous People, or UNDRIP, affirms Indigenous rights to self-determination, self-government, and non-discrimination, and it's integral to the relationship between Canada and the Métis Nation. The Canada-Métis Nation Accord also enforces UNDRIP, as well as the government-to-government relationship that we have, recognizing the Métis Nation as a distinct Indigenous nation with inherent rights, including rights to health and wellness. Métis Nation Saskatchewan is working with the Saskatchewan government and health agencies to identify and access Métis-specific health data in their records through our citizenship registry. Access to Métis-specific health data will allow us to identify the health profiles of Métis populations and know where to prioritize our health promotion efforts to close the gap of health inequities among Métis peoples. In many ways, we're still on a journey to ensure Métis peoples are identified, respected, and adequately served. In 2019, Métis Nation Saskatchewan signed a Métis government recognition and self-government agreement with Canada, outlining a pathway for the Métis Nation in Saskatchewan based on our distinct culture and inherent rights of the Canadian Constitution, Section 35, specifically, to address inequities related to the social and economic barriers Métis people have been experiencing for many generations. The Métis health research and data governance principles emerged out of a partnership between Métis Nation Saskatchewan, Dr. Caroline Tate, a team of researchers from the University of Saskatchewan and the Saskatchewan Health Authority. The partnership created a framework for researchers and health agencies to promote equity in health and well-being for Métis people, which are supported by UNDRIP and the Canada Métis Nation Accord. The project was funded by the Canadian Institute of Health Research and supported by the Saskatchewan Network Environment for Indigenous Health Research, or the NEAR Centre.
So for Métis Nation Saskatchewan, decolonizing policy begins with respecting our Métis self-determined health research and data governance principles. These principles include, as you can see here, honoring Métis self-determination over health research, data and policy, including ownership, control, access, and stewardship of research and data. Building reciprocal relationships through the meaningful and authentic engagement of research partners, respect for individual and collective autonomy, identity, personal values, gender, confidentiality, practices, and protocols across the research and knowledge mobilization process, safe and inclusive environments that are culturally safe and include different Métis voices and perspectives across the work of the research partnership, as well as all geographic and social context. Also recognizing the diversity of Métis perspectives and lived experiences that can influence the design of the research relationship and their processes. In addition to that, research should be relevant to Métis people who are involved in it, requiring community partners to identify research topic that Métis wants to undertake, have input into the design of the project and co-design the project and participate in the project's activities at all stages of the research. Métis context is important as well. Métis context requires researchers to be familiar with the history of Métis people, Métis government, specifically to local history and community or organization they are conducting research with. And finally, stewardship of the data requires a clear legal statement and agreement to ensure that Métis Nation retains its data sovereignty over research processes, data analysis and storage, and knowledge mobilization, even if the data is stored and protected by an external partner.
The Métis have often been referred to as the forgotten people for many reasons, including being vigorously pushed to the margins of society by previous Canadian governments. But it's important to note that discriminatory colonial practices still prevail. Métis people have been left out of existing federal Indigenous specific healthcare policies and programs. Jurisdictional disputes often exclude Métis people from both mainstream and Indigenous specific healthcare systems. While First Nation and Inuit access some of their programming through the First Nations and Inuit Health Branch of Indigenous Services Canada, the branch does not have a mandate to provide enhanced health support for Métis people. So Métis must access mainstream provincial services, services that often do not meet the specific healthcare, cultural, or geographical needs of Métis peoples. However, Métis Nation Saskatchewan has been working with Indigenous Service Canada to include Métis specific health services in their mandate. This is an ongoing discussion with the Government of Canada. In many ways, we are still on a journey to ensure Métis peoples are identified, respected, and adequately served.
So since we don't have access to health administrative data in Saskatchewan, we started going to our communities and consulting with our people in their communities. To understand the needs of our Métis communities, we engaged with more than 800 citizens over the past few years and asked about their experience using the healthcare system. This engagement provided us with a rich and in-depth understanding of Métis social determinants of health, challenges they face, and successful models of care and ideas that they have for improving healthcare system. As a result of these sessions, we have created culturally safe and relevant health support programs to support our Métis citizens and promote health equity in health and well-being for Métis, in collaboration with other Métis Nation Saskatchewan ministries, such as housing. This includes medical travel assistance program that we introduced during the pandemic, and we cover the cost of fuel, food, and accommodation for those patients who travel for their cancer appointments or dialysis appointment or general medical appointments that they have. We also created a holistic Métis specific mental health and addiction helpline where our intake officers, they take the client and refer them to Métis mental health providers in Saskatchewan. We also created a holistic Métis elder care. In some region, it's going on, some of our regions are providing that services to our elder, but in provincial level, we are still looking for some funding to start this project and cover the cost of, medications and health equipment for our Métis elders. And also there are other programs such as housing programs for first-time home buyers or home repair through housing department. These programs are addressing health from a Métis perspective, and they are filling in the gaps that exist in our current healthcare system. We will continue to work alongside our advocacy and partnership with the provincial and federal government to ensure there is a long-term and committed funding for Métis citizens to build relevant, respectful, and self-determined Métis-specific health and research surveillance project. As a result of this engagement and partnership with Cancer Agency, we were successful in entering into data sharing agreement with cancer agency, so we know have access to our Métis specific data in Saskatchewan.
And in closing, I would like to acknowledge our partners, the Mamawiikikayaahk Health Research Network and Dr. Caroline Tate and her research team, as well as the Canadian Institute of Health Research for funding this work. Merci.
Unmute. Thank you, Adel, to you and your colleagues for that presentation. As with our last speakers, the presentation was framed by acknowledging the legacy of colonisation, that all work is founded on cultural concepts of health, and in your presentation that emphasised, those concepts emphasised holism, self-determination, and connectedness to the land and place, and also Indigenous rights. So to me, this presentation drives home the point that decolonising health policy relies on being counted. So that is on recognition of the group's status and rights as Indigenous peoples, and also high quality data, and which includes, of course, quality ethnicity data, to inform health policy development and the monitoring of policy effectiveness. You identified Métis research and governance principles that provide a start point for decolonising policy, and they of course align well with Indigenous data sovereignty principles that many of us will be familiar with, that are about ensuring collective benefit for Indigenous communities from research using Indigenous data, Indigenous people's control over their own data, and grounding research in Indigenous frameworks and Indigenous ethics. But it's really great to see a localised approach that makes sense here and in your own context. And Indigenous data sovereignty, of course, has been defined by the International Working Group for Indigenous Affairs as the right of Indigenous peoples to own, control, access and possess data that is derived from them and which pertains to their members' knowledge, system, customs and territories. I said in your presentation that through your own consultation and research with your communities, this has provided an alternative source of quality data as a foundation for health service delivery, and that you're also negotiating data sharing agreements to access Métis data. And internationally, certainly here in New Zealand, there's a real growing interest among Māori around data sharing and Indigenous data sovereignty, and how we accommodate the very different views that we may have as Indigenous peoples around what is appropriate data to share, what isn't, and then as Indigenous scholars and academics, what the implications may be of our different views, or our views that might be at odds with the views of research funding agencies or journals. I'm going to turn now to some of the questions that have been put forward, but I would be really interested in asking a question myself, because my background is as a researcher too, around Indigenous data sovereignty and the types of principles that have been developed internationally through working groups, and whether you guys are part of that and contributing to that discussion, and how you might see that kind of more generic international work compared to localised principles or approaches that you might take.
Sure. Thank you for your question. You know, in general, in Canada, we have, First Nations data sovereignty that, it's called OCAP, ownership, control, access, possession. For Métis, because we are distinct, Métis is distinct Indigenous population in Canada, and they're, it's not, the Métis is not represented in federal government's Indigenous health branches. We had to work with the provincial governments or local governments to have our access to our own data. So we, it's kind of aligned with OCAP, but we have OCAS kind of thing that, ownership, control, access, and stewardship, because we build partnership, any data that we have. For example, recently we had an agreement with Saskatchewan Cancer Agency, and Saskatchewan Cancer Agency, their cancer registry is the stewards of our data. So they identified Métis individuals in their cancer registry. Based on the agreement, the data belongs to Métis Nation and Métis people. Métis Nation has access and Métis Nation has control. But we don't get all the data, raw data, and host in our servers. We give the stewardship of data to them, so they have it. But anything that they want to publish about Métis health status, it should go through Métis Nation Saskatchewan, because we have, control on what data has been gathered and has been published. Generally, having this conversation, building partnership works best for us, for Métis, as Métis in different jurisdictions in Alberta and British Columbia and Ontario. I know that Métis governments, they have entered into a data sharing agreement with their provincial government, so they have access to their data. They don't host the data, they get aggregate data, but it's in partnership with mainstream government or non-Indigenous government. We will work together to have access to our data. We are still working with the provincial government in Saskatchewan. We have made a huge, moving forward. We have the draft data sharing agreement, and hopefully we can identify our Métis people in their system. So the way that Métis people can be identified in healthcare system and health databases is that we provide them with the name and date of birth or their health card numbers. Like, as of now, we have 25,000 registered Métis in our registry. We have all the names and all the information. So we give this to the data provincial databases. They run through their system. They extract all Métis specific data, which is about 100% accurate. So that's how it works here. And since, once we get the data, then we know, for example, in one of our remote communities, people are suffering from kidney disease, or in another community, people are having tuberculosis, or there are lots of, emergency room attendance in specific parts. So we mobilize our resources and efforts to address those health needs in different communities based on the data that we know.
Mm-hmm. So other presenters have talked about the importance of a by Indigenous, for Indigenous approach to policy and to provision. To what extent is that an approach that you're taking in research, and how important is that approach?
Yeah, very good question. So that's one of our research protocols in Métis Nation Saskatchewan. Any any scholar or researcher who wants to do research in Métis communities, it's not that we shouldn't be afterthought. Code development and code design is the main principle for Métis Nation Saskatchewan in any research that involves Métis citizens. And we have been working with the University of Saskatchewan and University of Regina to show them that if any of your researcher wants to do this research, it's okay. Come to us. Let's work together. Let's co-design the research, and also if you're writing a proposal, let's co-design it. And then, you know, you can hold the fund, but if you're going to Métis communities, we need to know where you're going to do, because, you know, in the past, researcher has gone to many communities, and after they've done their project, knowledge is gone. It's not there. So the purpose of these protocols and processes that we have is to keep the knowledge in the community and give something to community as a result of that research. So co-design, co-development, and ownership of data is, and, you know, all the data principles that we had is important for Métis Nation Saskatchewan.
Well, thank you to you and your team for your presentation, and also special thanks to you for coming along and representing your team and being available to answer our questions. And I would let you go, but I've just seen one more question come in. So the question is around how to balance local data ownership and the need to demonstrate needs for specific health services.
Great question. You know, to balance the local data ownership in Saskatchewan, Métis Nation, government of Métis Nation Saskatchewan represent all local and all regions, all Métis across the province. So as just a background, Métis Nation Saskatchewan has 12 regions, and under each region we have different locals. Yes, it's, you know, the data belongs to the local, but how to balance it and, you know, bring it to the policy level is that, you know, any researcher, our research protocol says it should go through the government of Métis Nation Saskatchewan. I mean, if it's health, it goes through Health, Ministry of Health, and then we get the data. Then, you know, we see the gap in different areas. We haven't received any data, health administrative data or population health data or, you know, emergency room data. We haven't received it yet, but as far as I know that in other jurisdictions, they get this, you know, for example, diabetes, in some of areas, we know that it's hard for people to afford insulin or medication for diabetes. So we mobilize the resources there. We apply for different funding. We support our elders. So I don't want one of our, you know, this is again a story that I heard from one of our elders who couldn't afford purchasing their insulin. So they were, you know, reducing their insulin per week. So that's, I don't know that, because we don't have the data, but through our qualitative data gathering and through our, you know, conversation with our citizens, I realized it, and then I had, you know, some resources deployed to that region or to that person to save the lives. So that's how we work, and hopefully in the future we will have our own baseline report based on the access to data that we have, and then we monitor the trends of mortality, morbidity in different, you know, disease across the province.
Okay, thank you.
Thank you.
So I think we're going to finish off a little bit early today, but I've got a little bit more to say before we do finish off. And that, I think, the good thing is it's going to give you all a chance to have some input into the legacy statement and maybe draw on some of the things that you've heard, the insights from this session to inform your input. So we know, and the presentations today reiterated, that Indigenous peoples are hardest hit by inequities, and that health policies can exacerbate or reduce the disparities experienced by Indigenous peoples. As well as our presenters emphasised, for Indigenous peoples, the contemporary and ongoing impacts of colonisation are distinct and are the fundamental drivers of the inequities experienced by Indigenous communities. So this means that policy solutions to health inequity will need to address the ongoing impacts of colonisation and the resulting systemic racism within health and social systems. The stories that were presented in this session were unique, but at the same time, there are lessons that can be learned from these local experiences of Indigenous community mobilisation that have a wider application to policy development for Indigenous peoples around the globe, and that will advance structural change. So first, the vision, or what we're seeking to achieve, is wellbeing as it is understood by Indigenous peoples themselves. So in Adel's presentation, they talked about a holistic concept of wellbeing that emphasises self-determination, is grounded in secure identity. Minnie also mentioned connections to land and place, and also the inspiration that we get from the resilience and creativity of our ancestors. Second, policy needs to consider the social determinants of Indigenous people's health and take a rights-based approach. Thirdly, Indigenous peoples are committed to leading their own health development. And policy development and implementation has a transformational intent. So it's based on the rights of Indigenous peoples to good health, is carried out in an Indigenous way for the benefit of Indigenous people, and is based on Indigenous cultural foundations, draws on Indigenous knowledge, and relies on community mobilisation to be most effective. And the by Indigenous for Indigenous approach is therefore going to be necessary in order for policy that's developed in a way that fully aligns and understands Indigenous concepts of health and wellbeing, the nature of Indigenous worldviews, and the intellectual traditions that have given rise to these understandings. Next, effective policy relies on robust data, evidence, and insight generated through research that's consistent with localised Indigenous principles and Indigenous data sovereignty, and through the collection and analysis of quality administrative data. I just want to finish off with a couple of examples from here of Māori community mobilisation for health policy. One of those examples, I'll start first with often some of our presenters talked about the adaptation of Western policy to better meet the needs of Indigenous peoples. So in New Zealand, one of the approaches that we have taken to policy development is to use policy frameworks or policies that are based on Māori worldviews, but that are applied for the whole population. One of those policies is whānau order. And whānau order is about not only focusing on the outcomes that you want to achieve for individuals, but focusing on collectives, extended families. And so the whānau order policy runs across all sectors, and it is about how a more integrated approach can be taken to improving the outcomes for family groups in education and health and housing and all kinds of areas. And the concept of wellbeing that policy seeks to contribute to is a holistic concept of wellbeing. And some of you may have heard of the wellbeing budget that that the New Zealand government has in place, and that too is a budget that is based on a more holistic understanding of wellness.